Hey guys, so this, I think, third PowerPoint or video is going to be on pharmacological and non-pharmacological pain management. Um, and it's going to cover the medications you're going to need to know for the pain portion. Some of them are repeats from a previous lecture, and some are newer. And just some special considerations regarding medicating for pain. So, the first sets of medications are non opioid analgesics, and just know the word analgesic is um, something that relieves pain. So, we have NSAIDs or nonsteroidal anti inflammatory drugs like ibuprofen, aspirin, ketorolac, or I'm probably going to butcher this, but Selexcosib, nope, or otherwise Celebrex. Typically, those medications produce analgesia and reduce inflammation and are antipyretic or reduce fevers by inhibiting the production of prostaglandins. But they also can decrease platelet aggregation, and what that means is that it can have blood thinning properties. The other type of non-opioid analgesic is acetaminophen or Tylenol, and the way Tylenol or acetaminophen works, it inhibits the synthesis of prostaglandins that may serve as mediators of pain and fever in the central nervous system. And know that Tylenol or acetaminophen itself does not have anti-inflammatory processes. It relieves pain and can reduce a fever, but it does not have the same action as NSAIDs do. The other medications are called adjuvants, and when I think of the word adjuvant, it adds to it. It adds to that pain relief. The four included in your book are baclofen, cyclobenzaprine, tizanidine, and gabapentin. And typically, adjuvants are medications that are typically given for something else, for another purpose. For example, gabapentin is given for neuropathy, but it can also be used as a pain reliever, an analgesic. A lot of different kinds of adjuvants can be antidepressants. They can be topical agents, muscle relaxers, even corticosteroids can be used for pain management. The other group of pharmacological analgesics are opioid analgesics. Those include medications such as morphine, oxycodone, tramadol, Percocet, and just know Percocet has oxycodone with acetaminophen. And then Norco or Vicodin is hydrocodone with acetaminophen, hydromorphone or Dilaudid, and fentanyl. And the opioid mechanism of action binds to the opioid receptors in the central nervous system and alters the perception and response to painful stimuli while producing a generalized CNS depression. And just know that we have to be very careful with these types of medications because they do cause central nervous system depression. We would likely monitor things like respiratory rate, blood pressure, and pulse, because if any is too low, we would not administer it. We would see if we can use something else, but we don't want to cause any further respiratory depression. So if a patient's respiratory rate is borderline 12 breaths per minute or less, then we would really have to see if we could give something else other than an opioid analgesic. Just know that opioids are natural and some are synthetic, and they are great for pain relief, and they vary in potency. For example, a 2 milligram dose of morphine is completely different than giving a fentanyl dose and a dose of hydromorphone. If I remember correctly, hydromorphone or Dilaudid is about 10 times stronger than morphine. So those are typically given in smaller doses. And again, with fentanyl, the doses are even much smaller. They come in micrograms. So the potencies differ greatly in the types of opioid analgesic. The opioids work by finding pain receptor sites to bind with and block the pain impulses. Opioid receptors include mu, delta, kappa, and sigma receptors. However, mu receptors are most effective in relieving pain. So if the opioid analgesic finds and binds with mu receptors the best, then that will have the best pain relief. Some key things to know about opioid analgesics are tolerance, physical dependency, and addiction. And we'll briefly discuss what the differences are. So tolerance is an occurrence of the body's becoming accustomed to an opioid and needing a larger dose each time for pain relief. Whereas physical dependence is a phenomenon in which the body physiologically becomes accustomed to an opioid and suffers withdrawal symptoms if the opioids are suddenly removed or the dose is rapidly decreased. And lastly, addiction is a pattern of compulsive use of addictive substances for means other than those prescribed. So, and we have to look at the 3 different terms because we want to ensure that you understand that addiction is a disease while tolerance and dependence is not. We know that many medications can cause addiction, but not everyone is going to become addicted to opioids. We know that somebody that has a tolerance for opioids may need larger amounts of medication for actual pain management. The same occurs with somebody that has an addiction. And the reason that is because of the overuse of the medication will reduce the amount of receptors that can bind in order to give that pain management. We just have to understand that if somebody is physically dependent on a drug, that they might go through withdrawals. They might present with withdrawal symptoms. And just know that physical dependence can often lead to addiction of an opioid. So here we're going to talk about the different non-pharmacological measures. What that means is that they don't involve medication. Some different things would be cutaneous stimulation, such as a TENS unit or a PENS unit. So TENS is transcutaneous electrical nerve stimulation, and then there's percutaneous electrical nerve stimulation. There are spinal cord stimulators, acupuncture, acupressure, massage, the use of heat or cold therapy, and then contralateral stimulation. So let's start off with the TENS unit. Typically, it's a battery-powered device. Can be the size of a pager. I know some of you guys might not know what that is, but pretty small. And it is connected with electropads similar to those that look like an EKG, connected to wire, and then there's a stimulator. The pads are directly applied to the painful area, and then once activated, the unit stimulates A delta sensory fibers. And the A10s units can be worn intermittently for long periods of time, depending on the patient's pain. I've heard really good things about TENS units being used during labor to help a mother who isn't using an epidural to relieve pain. The other one is the percutaneous electrical nerve stimulation or PENS unit. It combines TENS unit with the percutaneous unit, and it goes through the skins, through probes, and it stimulates peripheral sensory nerves. PENS is it is effective in short-term management of acute and chronic pain. PENS therapy in some patients promotes physical activity and increases the sense of well-being while reducing the use of non-opioid medications and helps improve sleep. Spinal stimulators are used for chronic neurological pain, may be treated by a surgically implanted spinal cord stimulator. The SCS produces a tingly sensation that interferes with the perception of pain. Acupuncture, so that's the application of extremely fine needles to specific sites in the body to relieve pain. It is believed to stimulate the endogenous analgesia system. Acupressure stimulates specific sites in the body using fingertips to provide firm, gentle pressure over various pressure points. This process may have a calming effect through the release of endorphins. Patients can be readily taught key points to stimulate so that they can self-administer acupressure at any time. The use of massage can help provide cutaneous stimulation and relaxing the muscles, and massages can help reduce pain. The use of heat or cold application. So the application of cold causes vasoconstriction and can help prevent swelling and bleeding, while heat promotes circulation, which speeds healing. Use with caution these methods because the skin may be injured and it might be too extreme if either hot or cold. Contralateral stimulation. This is when you stimulate the skin in an area opposite to the painful site. Stimulation may be in the form of scratching, rubbing, or applying heat or cold. This intervention is especially helpful if the effective area is painful to the touch under bandages or the cast. Other forms of non-pharmacological pain management measures include oral sucrose, immobilization, and cognitive behavioral therapy. So for oral sucrose, that's for newborns. Sucrose by mouth alone or in combination with other analgesics can be effective pain control for newborns exposed to mild to moderate painful procedures. So this is used if the newborn is being poked. They will often give sucrose to help soothe pain. The other one is immobilization of the part. So think like a broken or a sprained ankle. They might be in a splint that may offer some pain relief. Sometimes the splints can be used for arthritic joints. And then cognitive behavior interactions are distraction. So this is, a method of drawing the patient's attention away from the pain, focusing on something else other than the pain. It is based on the belief that the brain can process only so much information at one time. When distraction works, the patient has only peripheral awareness of pain. Sequential muscle relaxation. For this, the person sits comfortably and tenses a group of muscles for 15 seconds and then relaxes the muscle while breathing out. After a brief rest, this sequence is repeated using another muscle. This is very similar to distraction because it uses the notion that the brain can only do so much at once. Guided imagery, so uses auditory and imagery processing to affect emotions and help calm and relax. Acute and chronic pain, physical and psychological, may respond to guided imagery. However, it is more effective for chronic pain. Other cognitive behavioral interventions include hypnosis, humor, expressive writing, and even animal-assisted therapies. I mean, who would not be happy to see a animal therapist? I mean, I would definitely be happy and my pain would go away if a dog came to my hospital bed. But I digress. Just know of these types of non-pharmacological measures, understand that not all types of patients they would work. So, and think of guided imagery and somebody that is cognitively impaired. Would they be able to follow that guided imagery? So it's knowing what is going to work for your patient. And then because we as nurses give opioid medications, we need to know what naloxone or Narcan is. Narcan is the reversal agent if somebody happens to overdose on an opioid medication, whether that's out in the field, in the ER, after surgery, whatever it is. We need to know what it is and how to use it. So with Narcan, you want to assess your patient for level of pain after administration. We use it to treat postoperative respiratory depression. We know that it decreases respiratory depression, but also reverses that analgesia. So your patient might wake up with pain if we give Narcan. To assess the patient for signs and symptoms of opioid withdrawals, because that might start occurring if that reversal agent is still in the system. So some of the symptoms are vomiting, restlessness, abdominal cramps, increased BP, and temperature. Some special considerations when you're managing pain and using pain medications or non-pharmacological interventions. So managing pain in the elderly. You want to know that pain can be particularly persistent. It is common among older adults, especially those suffering from degenerative spine conditions, arthritis, nightly leg pain, or pain as a result of cancer. Older adults are at great risk for undertreatment of pain because they and their caregivers may be reluctant to administer analgesics for fear of producing confusion, excessive sedation, drug interactions, and respiratory depression. There is a risk of overtreatment due to higher peak effect and longer duration of pain relief that they experience as a result of changes associated with aging. Poor pain management can result in falls, poor sleep, delayed healing, reduced activity, prolonged hospitalization, anxiety, and poor quality of life. It is important that pain is treated appropriately for our elderly patients. Some patients may not be able to report pain. This is where assessing pain appropriately and using the right type of assessment tool is important. Managing the pain in clients with addiction. So, and I think this is specifically opioid addictions. Know that addiction is a state of psychological dependence in which a person uses a drug compulsively and will engage in self-destructive behavior to obtain the drug. Many studies have shown that properly managed short-term medical use of opioid analgesic is safe and rarely causes addiction, with the exception of those with a personal or family history of drug abuse or mental illness. This is not to say that we will not be withholding any opioid medications from somebody that's addicted to them when they are complaining of pain. That is not our judgment. If a person with a opioid addiction or polysubstance abuse is complaining of pain, we still give them pain medicine and we give them the medication that is appropriate for them. We just need to know if they're currently using any illegal substances, because we don't want to have interactions. What if this patient came in to the emergency room and had been using fentanyl and, they're complaining of pain for whatever reason, and we give them more pain medication, then we can cause respiratory depression. We want to know what the patient is taking if they are addicted to anything, so that we can assess for any adverse reactions. Use of placebos. Placebos are those medications or even procedures that produce an effect in a patient because of implicit or explicit intent, not because of its specific physical or chemical properties. So think of placebos like the sugar pills. They technically don't contain any analgesic properties. However, some placebos work. As nurses, we don't administer placebos unless it's for a research study for control. And that would be very specific cases where even sometimes the nurses won't know that they're giving a placebo medication. We do not do placebos in the hospital. It is not an ethical thing to do. So, just to recap, you guys need to know your non-opioid analgesics, and know the various forms of non-pharmacological pain management measures. Because as nurses, we will administer a variety of them, and so knowing exactly what they are is important. Thanks.